Thank you, Elsie. We're running a little bit short on time. We had a lot to hear about from our panelists this morning. But before we break for lunch, I'll throw it out to the audience first. Does anybody have any questions they'd like to pose for any of the panelists? If you just speak up.
Hi, Lucy Sullivan, 1,000 Days. This question is for Pepe. You talked about two things. You talked about
Thank you. The vegetables that children are consuming, and you talked about you didn't actually unpack what kinds of vegetables children are consuming. And if I remember correctly from the Fabulous Fit study, it's French fries that are sort of the #1 vegetable that children are consuming. Can you talk a little bit about that? And then in terms of the early introduction of solids, I think part of the solutions that we need to look at is what food manufacturers are also doing in terms of labeling. Because a lot of complementary foods here in the U.S. Are labeled 4 to 6 months. So would love your thoughts on that. Thank you.
All right, I'll try to be brief. First of all, with regards to vegetables, and we could talk about all the colors of vegetables and have many slides with many colors that actually show and kind of paint the picture. You're right. The single most common consumed vegetable is potatoes, and the single most common way of consuming potatoes for toddlers in the U.S. is fried and salted. So now we could pick some battles with our agriculture friends as to considering a potato a vegetable, but that would be another part of the way that we break down the data, because it does make a difference. If you look at green vegetables and other colored vegetables, it tends to be the lowest frequency, not always necessarily the lowest volume. So that's just background. We can talk a little bit more about that, but it is correct. The variety is also suffers tremendously when you look at what is accessible and what is present. With regards to vegetable access, and we're talking about complementary feeding as it relates to starting in the first 4 to 6 months of age and going to the first 12 months of age. In North America, as opposed to other parts of the world, we do have much more commercially available vegetables and fruits for infants and children in that toddler age. And the majority of those now do not have added sugar and salt. As opposed to the biggest problem, which is parents introducing their table food and the table food containing vegetables, which has significantly more increase in terms of sugar and salt. This is a universal phenomenon. We're now beginning to publish the data that relates to same type of survey in China. And we found exactly the same thing. It's the added sugar and added sodium, and particularly of the house food that is fed to infants after 6 months, that contributes much more to the increase in sugar and salt than the actual commercial foods, which tend to be lower at that age. After 2 years of age, things radically change because the offerings and the possibilities increase. But as we saw, and I did want to make the point, if you can establish the pattern of food group intake much earlier, it is harder to change it later, for the good and for the bad. And that includes the percentage of calories that come from vegetables, which even when the diversity and possibilities of access change, remains the same.
Hi, I'm Lynn Parker with the Institute of Medicine, and my question is for Dr. Birch. The mothers who were in your studies on responsive feeding and teaching them to be responsive feeders, were those mothers working, and were their kids in child care? And do you have any sense or speculation on the implications for that combination of care between mother and child care provider, and how that would work in terms of responsive feeding?
Thanks, Lynn. Great question. We do have those data, but we haven't analyzed them yet, so I can't really address your question. But we do have plenty of, particularly first-time moms, who are going back to work somewhere along the way. So we should be able to look at that.
Yeah, can I ask a quick follow-up to Dr. Birch? I wondered, do you have any data on whether the moms who were in your intervention saw any changes in their own dietary intake or weight, postpartum weight?
That's another one that I can't address, but I think we should be able to. Yeah, we have the data.
Thank you. Shariki Kumanyika, roundtable member. I was particularly interested in both Dr. Birch's comments about not knowing how this would generalize to higher risk populations, and then Dr. Taveras' comment about the section on disparities. What I'm thinking is that we know a lot more about some of these differences from studies of adults. So it's kind of like when you say, well, kids aren't born age 2. African American children are not unlike African Americans at older ages in terms of the social context. So if you look at adult cardiovascular literature, you'll see sleep coming out as a big thing. I mean, I first heard about nocturnal dipping, looking at hypertension in adults and non-dipping behaviors and so forth. So I guess this is a suggestion, or if you have comments as well, that when we take this slice of the age, we don't forget that there's a vertical way of looking at this, and we may be able to accelerate our understanding of the children at this age by looking at what we can do about the context that they live in.
Response or a reaction?
No, I completely agree. I think the reason why we actually started looking at sleep was because of the tremendous disparities among African American populations. But you also mentioned something, Shariki, that I think is really important, which is contextual influences and how we learn from adults some of the research and implications for children. So, I was in clinic last week, and a mom who herself is struggling with obesity was there with her child, and we were talking about sugar-sweetened beverages, and she's like, you know what, Dr. Taveras, you have to understand that, in the Caribbean, where water quality was terrible, it's understandable why we would seek to drink something that was bottled. Or, in my country where infant mortality was high and we saw stunting, there's a reason for a chubbier child being healthier, or, we're eating for 2. And so it's really interesting, I think, to understand the contextual influences, just as you said, that influence adult behaviors and how that could translate to choosing potentially, formula that comes in a bottle versus breastfeeding, and some of these influences that actually do come from the adults in the family. So I think it's an important point.
Hi, my name is Diana. I'm a doctoral student in maternal and child health at the University of Maryland, and I'm hearing some mixed messages in some of the things that have been said today, in that we know that duration and exclusivity of breastfeeding is an important protective factor against childhood obesity. But then we're also hearing now that limiting the number of night wakings and having children that sleep by themselves and that that take fewer night feedings is also a protective factor. But knowing what I know about infant behavior, that the two seem almost mutually exclusive, and I'm wondering if there's been any work done or any consideration to sort of teasing those factors apart from each other. And because we do know that proximal sleep actually leads to better sleep quality and duration in both mothers and their infants. So just in terms of breastfeeding versus formula feeding in that 0 to 6 month period, which, how should we be counseling moms? How should we be, do we want them to have their infants sleeping, as quickly as possible for as long as possible? Or are we really looking at breastfeeding even if it means less sleep? Thank you.
So the recommendation, if we're trying to promote exclusive breastfeeding, of course, is breastfeeding on demand. But my interpretation of Leanne's intervention is that they didn't intervene at all in terms of telling moms that they shouldn't breastfeed at night or or whatnot, that essentially their intervention about responsive feeding ended up with babies perhaps being more calm and being able to sleep longer at night. But I don't think your intervention involved scheduling breastfeeding in a different way.
Right. I mean, we were really trying to teach whether moms were feeding breast milk from the breast by bottle or feeding formula. They were really encouraged to learn to recognize infant cues, whether babies were hungry or distressed for some other reason, and taught alternative soothing strategies to try as a way of trying to sort out what the baby was trying to tell them. By all means, they were feeding babies when they indicated they were hungry. But feeding works as a way to calm an infant for some other reasons, whether they're hungry or not. So parents were encouraged to try minimal interventions first to see whether the baby would settle and go back to sleep, and then if the baby was still fussy, then feeding was a reasonable response.
If I could just add one quick comment, and this actually comes from data from IFPS2, for example. The responsive feeding applies across the board, whether you're breastfeeding, whether you're formula feeding, doesn't mean that you do more or one or the other. And of course, they're inextricably linked to sleep opportunities depending on soothing behaviors or calming behaviors, et cetera, et cetera. Even in bottle feeding per se is something that can be taught better than we teach today. If you look at the IFPS studies, or at least the lead paper published very together with the others, in fact, those infants receiving human milk in a bottle, exclusively in a bottle, actually gain more weight than infants receiving formula in a bottle. So there's as much to teach about bottle feeding than there is to breastfeeding. One is not mutually exclusive, but the important thing is that the behavior that comes with either is what we need to promote. Aside, of course, from favoring the continuation of breastfeeding for as long as possible.
Well, first, thank you all for those presentations. Those were great. Rafael, I was curious in one of the meta-analyses you cited that the protective effect of breastfeeding was greater after 1980 than before 1980. And you alluded to some formula differences. Could you expand on that? That may be an important insight.
Yeah, well, it was pure speculation that perhaps, for example, if the protein levels, the protein concentration has changed, the other components in the composition of formula have changed, that may explain why we see that secular trend. But I really don't have any evidence to support that right now. It's speculation.
I should add that despite the efforts of the formula manufacturers to try to align their formula with breast milk, they don't seem to be succeeding, at least in terms of its effects on weight.
Right.
And you had
I just had one quick follow-up. In the studies that you cited looking at the effects of early breastfeeding on weight status later in life, do you know in any of those studies if they adjusted for dietary intake in the interim?
That's a very good question, and most of them they have not. Most of them are really, even if they describe them as prospective studies, there have been huge gaps.
I mean, given that we know breastfeeding can be a marker of other healthy behaviors that mothers are choosing or not choosing.
But they do, they do adjust for socioeconomic status and as many confounders as possible, but not
diet.
Usually they don't have diet.
Of when they would be breastfed and when the measurements are
huge gap
during childhood.
Huge gap that needs to be filled there, yeah.
Time for one more question.
Hi, Linda Schack from the David and Lucille Packard Foundation, and thank you to this panel. I thought it was really great how you really gave a full picture, not just of what infants and toddlers should be consuming, but how they should be fed. And with the development of the USDA's dietary guidelines for 0 to 2 on the horizon, I'm curious sort of what are the implications of this conversation on that, and just curious any thoughts you have about the development of guidelines for young children.
Question.
I'll take one first, quick crack at this. First of all, I think one thing we probably should not call them is dietary guidelines because they go far beyond just diet. And they should probably guidelines for healthy growth or something similar to that if we are going to do this, because as I think we talk more and more has to do with how and the environment than just the food, even though that's obviously a critical factor. So I think it is important to take a much more holistic approach as it relates to the guidelines, especially from 0 to 2, if not from 0 to 4, that relates to, it's just not the guidelines about diet, but it's going to be the guidelines about how to grow healthy. And that includes activity, and that includes responsive feeding behaviors, and that includes the right choices of those behaviors as it relates to diet.
I think that is a good, go ahead.
Do a follow-up as someone that has had the pleasure of serving twice in the Dietary Guidelines Advisory Committee and now contributing to the B24. I would say that for the U.S., it is a huge step forward. The very strong likelihood that by 2020 there will be dietary, hopefully some degree of physical activity guidelines for children under 2, because that is a huge gap that we know exists based on the maternal child life course obesity cycle that has to be there for it to be addressed with the proper policies.
I think that question of what should those guidelines look like for the 0-2 population would be good to carry on during our lunchtime, so we'll end at that. Just a logistical reminder before we break for lunch, Jennifer McDougall from Blue Cross and Blue Shield of North Carolina Foundation will lead us into the afternoon session, beginning session at 1:30. I encourage you to walk around the building and look at the various art exhibits, and if weather permitting, go out and enjoy the nice weather. There's a walking map that's in the program, and enjoy your lunch. Thank you again, panel.